In this lecture, we're going to turn our attention to one of the most common examples of point-of-care ultrasound applications, which is using POCUS to examine the inferior vena cava. As you know, the IVC is the primary site of venous return to the heart from the lower part of the body. Due to its location and course through the diaphragm and liver, we can see it quite readily in most cases by imaging through the liver. And in many patients, we can displace bowel gas well enough to visualize the IVC from the anterior aspect as well. The IVC has a direct connection to the right atrium, and distinguishing where the RA begins and the IVC ends on ultrasound can sometimes be a challenge. The IVC is thought of as being a capacitance vessel, which means that it can expand to fill with as much volume as able, provided by the hydrostatic pressure of the venous system, while also being influenced by the external forces caused by changes in the intrathoracic and intra-abdominal pressures. Well, looky there, everyone's favorite slide is back. Now, remember that POCUS is a tool that's designed to answer a focused clinical question. So, what do you think the clinical question that we're usually trying to ask is when looking at the IVC? Because of the IVC's ease of visibility and the role in providing venous return to the heart, it seems like the perfect place to use ultrasound to non-invasively examine a patient's hemodynamic state and determine whether or not patients should receive fluid or be diuresed, or determine the etiology of a patient in shock, right? I mean, for decades it's been used for these purposes. But the problem is the evidence doesn't really support this. We'll discuss what the evidence does support and some reasons why the IVC fails to live up to our expectation of such a marker. But let's first go over how to image the IVC. Our probe of choice for imaging the inferior vena cava is going to be either the curvilinear probe or the phased array probe. Both are suited to the task. In practice, I often reach for the phased array probe myself because I often want to use the smaller footprint of the probe to my advantage, as it can nicely fit between ribs to image windows through the intercostal spaces. I'm also utilizing imaging the IVC as parts of protocols such as the Rush exam or VEXUS, and no worries if you don't know what those are just yet, you certainly will. But oftentimes with protocol-based exams where I'm taking a look at multiple different organ sites or organ systems, I reach for the phased array probe as a good general workhorse transducer. But feel free to use the curvilinear, live your life, do whatever you want. In general, we will image the IVC with the patient laying supine for the easiest views and the most intuitive conclusions. There are two main windows for viewing the inferior vena cava. The first is a subcostal window, in which the probe is placed just caudate to the lowest rib at the mid-sagittal line and translated laterally towards the patient's right side until the IVC comes into view in the far field of our image. This view is attainable in most patients, but occasionally due to habitus or bowel gas or cases of critically ill patients who are receiving CPR, it may be easier to view the IVC by using the liver as an acoustic window. That view, called the transhepatic view, is also utilized in pregnant patients due to the displacement and obscuration of the IVC by the gravid uterus. There's no preferred view, so once again, feel free to choose your own adventure. Regardless of which window you choose to look at the IVC, it should be interrogated in both the longitudinal or long axis views, as well as in the transverse or short axis view. Remember that the surrounding organs include the digestive tract, which can easily obscure deeper structures if the ultrasound beams contact air bubbles in the stomach or intestines. Solid organs such as the liver and kidneys can be seen depending on the probe placement and depth. I'll be using these schematics to correspond with some example images. When viewed from the anterior or subcostal window, the inferior vena cava will appear in the long axis as a roughly linear anechoic structure in the far field, located superficial to the bony reflections of the vertebral bodies. Care should be taken to avoid mistaking the abdominal aorta for the IVC. Pulsatility and compressibility, which we often use to look at peripheral vessels and help differentiate arterial and venous flow, is not reliable in the case of the IVC. Firstly, pulsatility is often seen in the IVC due to movement from the adjacent aorta or due to respiratory and cardiac cycles with pressures being transmitted back from the heart down the IVC. Second, not only is it probably a bad idea to try and compress the main avenue of venous return to the heart, but it's often difficult to do so due to the depth of the IVC and dispersion of any compressive forces through the abdomen. If there is doubt about whether a great vessel is the IVC, use color flow to determine the direction of flow for confirmation. When viewed in the long axis from the transhepatic view, the IVC is often seen concurrently with the aorta due to the IVC's location lateral to and sometimes slightly anterior to the course of the abdominal aorta. Some people call this the double barrel view. Either the subcostal or the transhepatic view is adequate for visualizing the IVC in the long axis. Here's a closer view of the IVC in the long axis image from the subcostal margin. Note that the probe setting is cardiac, so our probe indicator marker is on the right side of the image corresponding to the cranial direction. For this reason, we see the heart on the right side of the image and can see how the IVC opens directly into the right atrium. We can also see the hepatic vein joining the IVC quite close to this junction, with the hyperechoic line of the diaphragm separating the two. This area is traditionally where the IVC diameter is measured, but we will discuss this more in a bit. Here's a close-up view of the IVC and a glimpse of the abdominal aorta in that double barrel view corresponding to the transhepatic window that I talked about earlier. Again, we have a cardiac probe in the cardiac preset, which we can tell from the transducer's narrow triangular footprint and the location of the probe indicator marker on the right side of the screen. Again, we see the IVC and the hepatic vein joining closely to the confluence of the IVC and the right atrium, although the heart is not easily seen in this still image. The old ultrasound adage is that one view when looking at a structure is equal to no view at all. And so let's talk about imaging the IVC in the short axis. We should always image in both the long and short axis when able. Once again, we have two windows through which to view the IVC in the short axis in the same positions as before. At the subcostal view, we see the liver in the near field with circular or elliptical anechoic vessels in the mid to far fields located anterior to the bright reflection of the vertebral bones. In the transhepatic window, we see the IVC in the groove of the liver as it approaches the diaphragm. Here's just another look at these images a bit more zoomed in. See if you can identify which one is the transhepatic view and which is our subcostal view. If you said that the left image was the subcostal view and the right was the transhepatic, that was correct. Good work. Part of the challenge POCUS nerds have faced with the IVC arises from the fact that there are several difficulties that arise when making measurements of the IVC. Let's talk about some of them and explain how to make the best measurements we can, even when they are limited in the information that they can provide. One of the first challenges that we're faced with when measuring the IVC diameter is due to the basic geometry issue with slicing a cylinder. If you cut a cylinder in half and do so perpendicularly, you get a circle in cross-section. But when done at an angle other than perpendicular, the resultant cut shape is an ellipse or oval. Even small variations in the course of the IVC or the angle of our probe can thus have a disproportionately large change in our measured diameter. In the long axis, when cut longitudinally or hot dog style, if you prefer to use that term, my mom was an elementary school teacher, so we definitely said hot dog and hamburger style in my house. Being off-center similarly affects the height and thus diameter measurement of the IVC. So if we measure it right in the middle versus over on the side, we'll get different measurements. Not to mention, but the IVC isn't a perfect cylinder to begin with. Due to its location somewhere between the liver, the aorta, the vertebral bodies, and all the other junk in the abdominal trunk, the IVC often gets a bit squished into more of an oval shape. So here you can imagine how variable measurements would be if taken from slightly different spots or angles. To make things even more complicated, remember that the IVC has a variable appearance even in hemodynamically quote-unquote normal patients. I mentioned up front that the IVC is a capacitance vessel, and that due to the respiratory cycle's effect on the intrathoracic pressure, even a normal IVC will dynamically change shape depending on the cardiac and respiratory cycles. Here's an animation of such an example. Here we see the IVC in the long axis from an anterior subcostal window. We can also see the heart with the connection of the IVC directly into the right atrium. Notice that when this patient inspires, which we can see based on the diaphragm contracting, the portion of the visualized IVC between the right atrium and the hepatic vein partially collapses due to the decrease in intrathoracic pressure caused by the diaphragm's contraction. It's important to note that a spontaneously breathing patient will have different forces affecting their intrathoracic pressure and, by extension, their IVC, than a patient receiving mechanical ventilation with positive pressure. With inspiration, spontaneously breathing patients drop their intrathoracic pressure, resulting in a net forward flow of blood from the IVC into the thoracic cavity and right atrium. Alternatively, in positive pressure ventilation, air is pushed into the lungs during inspiration, resulting in a net increase in the intrathoracic pressure and thus reflux of blood backwards into the IVC. So we've talked about how IVC measurements are, 1, hard to obtain to begin with due to their geometric properties, 2, variable based on where the IVC is located in the body, and 3, affected immensely by thoracic and abdominal pressure changes. Now, what if I also told you that because there can be significant variation in the IVC anatomy, there's also not a great consensus about how and where we should even measure the IVC diameter, or whether we should use static images or M-mode, and there's a lack of great inter-rater reliability at said measurements. For example, look at these two images. Using the traditional teaching that we should measure the IVC a couple centimeters below the confluence with the right atrium, both of these would have similar measurements, right? And yet we can tell that the IVC in the image on the right is significantly more narrow than the one on the left along the course of its trajectory. So what is the clinical significance of this? Well, join the club if you're asking this, because we're all asking similar questions and nobody has really proven that there's a definitive, high-quality evidence that IVC measurements can be predictive of fluid responsiveness. All right, you guys know I love a good soapbox, but let me step off of mine for now. Because I'm going to be critical of IVC ultrasound, I should at least tell you how to gather the data. Who knows, maybe one of you will develop a study that will clear all of this up for us. So now let's go over the classic teaching for IVC assessment using ultrasound. The IVC diameter and collapsibility, as measured near the confluence of the hepatic vein and the IVCs emptying into the right atrium, has been shown to be related to the relative central venous pressure. So to put it simply, large dilated IVCs that do not collapse with inspiration represent IVCs with higher central venous pressures. And conversely, small diameter IVCs that do collapse to a fair degree correlate with lower central venous pressures. Now, if you mix and match these, you're somewhere in the middle. Now, based on averages taken using invasive pressure monitoring and comparing that to ultrasound measurements, we can use our IVC diameter and collapsibility to roughly estimate the central venous pressure, and the data does seem to back up its reliability as an estimate. Traditionally, each of these categories, high, intermediate, and low, are ascribed the values of pressure seen here, or 15, 8, and 3 millimeters of mercury respectively. Remember, these are averages, and while useful for categorizing patients into silos and making more advanced measurements of cardiac function, these values are not exact, and they don't apply to populations such as patients receiving PPV. The information presented on the last slide about the IVC diameter and collapsibility being correlated with the measured pressures may give you some hope for IVC's utility. It seems logical that hypotensive or shocky patients would have a low central venous pressure and thus a low amount of venous return, be smaller and more collapsible, and thus we can jump to the assumption that giving those patients fluid would be helpful for correcting their hypotension. However, this line of thinking is wrong. You see, just because the IVC can predict the central venous pressure, it cannot predict how patients will respond to fluids. Similar findings have shown that even invasive monitoring of the CVP, while definitely accurate, it's not predictive of fluid responsiveness. I love this diagram that I found in the referenced article below, which, if I haven't mentioned it already, is a really great read if you're interested in ultrasound, critical care, or just a sassy clapback. Like so many things in medicine, what we would like to be a simple, straightforward causal relationship rarely is. So I alluded to this earlier, but it's critical to recognize that central venous pressure is not predictive of fluid responsiveness. This article, published in Chest in 2008, was a saucy little call out from critical care physicians who recognized this, that 93% of critical care docs reported using the central venous pressure estimations or measurements to drive decisions in whether or not to give fluids to patients. The authors looked at over 20 studies that comprised over 800 patients and found no data that indicated that the CVP should play a role in the determination of physicians to give or withhold intravenous fluids. And as they did their search, which initially returned over 200 articles that had explored research about the central venous pressure in both human and animal models, there was only one study that showed a strong relation between the CVP and fluid responsiveness, and this was in the study of 7 horses, or mares, undergoing a controlled bleeding. And so that's where they got this really creative title of Does Central Venous Pressure Predict Fluid Responsiveness? A Systemic Review of the Literature and the Tale of 7 Mares. One of the best article titles was born. So why doesn't the IVC predict fluid responsiveness? All right, I'm back on my soapbox. For these reasons and many others. Look, if there's one big takeaway from this lecture, this is what I want you to remember. Before we write off the IVC completely, let's talk through the pros and cons of looking at it. The pros, the IVC is relatively easy to find. Ultrasound is non-invasive. The findings could be helpful in ruling in or out some emergent conditions. And there are certainly some limited uses for the IVC measurements, like estimating the central venous pressure, if we're going to use that data to calculate a right ventricular systolic pressure, for example. And these are validated by the evidence. It's also something that, at least for now, you may see on your ICU rotation or in the ER. And look, I don't blame them. Our ER and critical care colleagues are making life and death decisions on the sickest patients in the hospital. And anything that seems like it may be a way to find some guidance to help figure out what to do in these cases is something I would also consider doing. But the evidence just doesn't back it up. Now, for the cons, we know that the IVC varies a ton in the way it appears between patients or even along its course in the same patient. There aren't great evidence-based conclusions about how or where to measure the IVC, and interpretation of any measurement rely on nuanced understandings of the hemodynamic state of an individual, which is often in question, and thus the reason we would want to ultrasound a patient in the first place. And lastly, the biggest con is that there are emerging, better, more comprehensive ways of examining patients with ultrasound to direct clinical outcomes. We will explore this concept in the second half of this lecture as we talk about VEXIS. So where does that leave us? The evidence does support IVC ultrasound for quickly ruling out obstructive shock. If it ain't dilated, it ain't obstructive, and fluids won't solve that problem, and in some cases could make it worse. The evidence supports looking at the IVC for small IVCs that fully collapse. Those patients usually are volume down and can likely get fluids for hypovolemic shock. However, by the time the IVC is dry, this is also usually clinically evident without an ultrasound, so meh. Lastly, measuring the IVC changes over time may be a helpful marker for tracking response to our interventions. How? Well, that's still being debated, but the evidence is pointing that way. And then lastly, not that this is really something that the evidence supports, it is helpful for identifying things that we're placing inside the IVC. So if you want to see if there's an IVC filter or a catheter that's supposed to be there, you can use ultrasound to look for it, but not a common thing that I do. So now let's turn our attention to the new kid on the block, VEXIS, or venous excess ultrasound. To understand the point of a VEXIS scan, we need to really reframe our clinical question. So what if, instead of trying to use POCUS to identify patients who are fluid responsive, aka who would benefit from receiving fluids, to instead try to identify a population of patients who would be intolerant of a fluid challenge? That question is at the heart of venous excess ultrasound, which popped onto the scene around the year 2020. VEXIS combines a view of the IVC with further risk stratification by looking at the ways venous congestion can manifest in some of the organs most affected by volume overload, the liver and the kidneys. Moreover, the evidence base for the use of VEXIS continues to grow, in many cases outperforming isolated IVC ultrasound for similar clinical questions. Higher VEXIS scores have been associated with higher right atrial pressures, increased risk of mortality, and possibly predictive of some clinical outcomes such as acute kidney injury while hospitalized. The VEXAS protocol starts with an evaluation of the IVC diameter, as we discussed in the first half of this lecture. If the IVC is dilated, you continue on to steps 2 to 4 for scoring. If the IVC is less than or equal to 2 centimeters, these patients will likely not have clinically significant venous congestion and bolus away if you think those patients need it. Step 2 of the VEXAS protocol investigates the hepatic vein, looking at variations in its flow patterns to determine if flow is normal or abnormal. The hepatic vein Doppler waveform is a complex, often triphasic waveform. The hepatic vein is imaged by placing the probe on the mid-axillary line with the probe indicator oriented towards the patient's head. Then, rotate the probe and fan until the hepatic vein can be seen flowing into the inferior vena cava. In this view, we're reviewing the hepatic vein from the side of the body, through the liver. Remember that forward flow, representing flow that's positive, is actually retrograde in the body. So this is flow that's going to be a positive velocity flowing towards the probe, and that means flowing away from the heart or retrograde. Meanwhile, velocities that are presented below the zero value are negative in velocity, meaning that they're moving away from the probe, but this is representing flow towards the heart or anterograde. In a normal hepatic vein, the waveform is generated by specific elements of the cardiac cycle. First, the A wave is a positive deflection caused by atrial contraction. The contraction of the right atria generates just a small pressure gradient that mostly pushes blood into the right ventricle as the atrial kick. However, a smaller amount of blood will reflux back into the inferior vena cava, resulting in a small retrograde flow, which presents as a positive deflection due to our probe being placed closer to the upstream end of the visualized vein. Next, the right ventricle will contract, and does so in such a way that the tricuspid annulus moves towards the apex of the heart. This results in stretching of the right atrium and essentially sucking up blood like a siphon out of the IVC. This results in a large anterograde wave flow, seen as a negative deflection on our spectral Doppler waveform, representing the S wave. The V wave represents an inflection point, where flow either returns to baseline or might slightly be retrograde, and results as flow when it stops or slightly rebounds after completely filling the right atrium and ventricular relaxation. And then lastly, the D wave represents diastole, where the tricuspid valve opens and blood will move anterograde to fill the awaiting ventricle in preparation for the next cycle. When there is venous congestion present in the liver, several changes can be seen in the morphology of the spectral Doppler waveform. The first change to occur is a relative weakening of the S wave amplitude, resulting in an S wave that is smaller than the D wave. Why does this occur? Well, in a venous congested state, there's excess pressure from excess blood in the right side of the heart, and this will cause dilation of the tricuspid annulus. What this results in is an increased amount of tricuspid regurgitation that happens during systole. In mild cases, this small jet of fluid moving backwards into the right atrium will just blunt the overall forward flow of blood from the IVC into the right atrium. You sort of have flow moving one way, and it's like you have a tiny little hose pointing the opposite direction, and those two forces are trying to balance out. And the net effect is that that S wave gets smaller, but is still moving the right direction, towards the heart. Now, in severe cases, the amplitude of the S wave can actually be reversed. Now, the biggest challenge with the interpretation of this section of VEXAS is identifying which wave is which. So here's a couple hints. The quick and dirty way is to assume that the wave with the largest positive amplitude is the A wave, and it will be in most cases. Now, the better way is to use a cardiac monitor, either hooked up to the ultrasound machine or running in tandem with it, to trace the myocardial activity in sync with spectral Doppler tracings. And you should note that your A wave syncs up with your P wave on an EKG. So, in summary, step 2 involves investigating the hepatic vein with spectral Doppler. If the S wave is larger than the D wave, this is a normal pattern. In mild venous congestion, the S wave will have an amplitude smaller than that of the D wave, and in severe congestion, the S wave will reverse and generate a positive deflection signifying retrograde flow. Step 3 of VEXAS involves an investigation of the portal vein. Once again, our probe will be placed in the mid-axillary line, but will typically need to be translated posteriorly and caudally to be positioned best. I think of my starting position here as being similar to the place where I'd place my probe if I was looking for a fast exam in the right upper quadrant. I'm looking for the liver and the abutting right kidney, and then once I have that view, I'll fan anteriorly until I see the portal vein come into view. In contrast to the waveform seen in the hepatic vein, the portal vein should exhibit continuous flow towards the transducer. However, the amount of pulsatility is what can help us identify venous congestion. To help determine the degree to which our portal vein is experiencing venous congestion, we have to do a quick calculation and get something called the pulsatility fraction. To do this, we map our spectral Doppler wave and then measure the maximum velocity and the minimum velocity. To calculate a pulsatility fraction, we subtract the minimum velocity from the maximum and divide the result by the maximum to get a percentage. So here, this example, we can see a very minimal amount of pulsatility throughout the cardiac cycle. But when things start to get more congested, we see a little bit more pulsatility. And the difference between the maximum velocity and the minimum velocity starts to increase, resulting in a higher pulsatility fraction. Remember that the portal vein collects blood from the GI tract and carries it to the liver, where it then branches out into portal venules and then connects to the hepatic vein via hepatic sinusoids, which function sort of as a sponge or capillary network for the hepatocytes to process the blood. Because of these sinusoids, the pulsatility pattern seen in the IVC and the hepatic vein are not usually transmitted to the portal vein, because the sinusoids act as sort of a dampening agent. However, when venous congestion causes these hepatic veins and the venules to overfill, they back up into these bloated sinusoids, and thus there's a more direct connection between the IVC, and thus pulsatility can be transmitted through the liver and into the portal vein. And that's essentially what we're trying to quantify here. So for a normal portal vein, there should be minimal pulsatility. If there's moderate venous congestion, there will be some pulsatility, more than 30%, but less than 50% of their pulsatility fraction. And then in severe congestion, there can be pulsatility fractions greater than 50%. So now we know how to get through steps 1 through 3 of the VEXAS protocol. There's only one step left, and that is to look at the renal vein. The renal vein Doppler is probably the most difficult of these steps to capture, and I usually leave it for last for the reason that because if there are severe findings in both the hepatic vein and the portal vein, there's really no added benefit to doing the renal portion of the exam. I'll explain that when we get to how we score a VEXAS, but just keep that in mind. The probe placement for obtaining this view is similar to our previous views, somewhere along the mid-axillary line with a probe indicator marker oriented towards the patient's head. For this exam, you'll translate the probe as needed posteriorly until you see the kidneys in the long axis, or right kidney, you only see one at a time. For this view, we want to target not the renal pelvis, but actually one of the vascular branches that run between the renal periods, or the intralobular veins. When placing our Doppler gate over the intralobular vasculature, we will often get a waveform that exhibits both arterial flow in the positive direction and venous flow in the negative direction. What we're looking for here is whether or not the venous flow is continuous or interrupted. In states of mild venous congestion, the venous flow is limited to 2 periods, corresponding with the S and D waves that we saw earlier on the hepatic vein section. Similarly, in severe congestion, this S wave will reverse and be lost inside the arterial waveform, leaving only a D wave. The interpretation for this step is not very difficult, but it can be a challenge to obtain a clean, precise waveform. But this is something we'll practice together. So, in summary, the renal vein pattern, as continuous or interrupted with distinct S and D waves, or interrupted with D waves alone, help us score this final step of the VEXAS protocol. So, now that we've obtained these results, how do we interpret them? The venous excess ultrasound protocol is scored from 0 to 3, with higher numbers corresponding to higher levels of venous congestion, and thus a decreased likelihood that the patient would tolerate fluid administration. A score of 0 suggests little congestion and is only scored when the IVC is 2 centimeters or less in diameter. If the IVC is larger than this, but no severe patterns are discovered, then the VEXA score is 1, suggestive of mild venous congestion. These patients may have a slight AKI or development of some slight pulmonary edema with fluid administration, but they might also respond well to fluids in some conditions. So this is really where your clinical judgment comes into play. Scores of 2 and higher indicate that severe patterns are present, with only one severe pattern earning the patient a VEXA score of 2, and at least 2 abnormal patterns being scored as a 3. Patients who have a VEXA score of 2 and 3 generally do not tolerate fluid administration, and a higher score can be predictive of worsening outcomes. So what does the evidence say about VEXAS? Well, it's a new protocol, but early indicators are that it outperforms measurements made using the IVC alone in a variety of ways. It has a higher correlation with elevated right atrial pressures, and it has been shown to be predictive of AKI development in critically ill patients. Serial VEXA scores have been described as being helpful endpoints for patients receiving diuresis, and there are many studies underway currently that apply this protocol to new clinical questions. So the big takeaway from this lesson should be that while it would be very helpful to have an easily measurable value using POCUS that could guide our management of patients with uncertain hemodynamics, the evidence hasn't really backed it up. While you see people relying on the IVC ultrasound to guide their clinical decision-making, you should think carefully about whether or not that data point fits into the overall clinical picture of the patient and use your critical thinking skills to make these decisions without relying on the IVC's appearance alone. That being said, there are some ongoing areas of research that may prove more useful in the future, but only time will tell.